Thank you very much. Let me to do it and try to explain what happened with that new form to do it, the surgery in UV. In UV, maybe you only thinking in decompression, in screws, hernias, and cervical, thoracic, and lumbar spine. But it's necessary to change that platform at that part of the thinking and the form to you do that. Because right now in the world changes a lot of things. Obviously is try to do it from minimal invasive spine surgery. That part is the more new happened in the world. Let me to introduce all my fellowships. You see it in the up part of the screen. Every one is part of my life because change every things, every idea, every form to do it, the things, change my form to do it and try to be best every day. When we open to the discuss and this chart is to try to explain what happened with the malformation of the Chiari. In the malformation of the Chiari, no, it's only the tonsil descends. Is all the change with that. When you know what is a part of the brain stem, you know you have a problems with the heart, you know you have a problems with the breathing, you know you have a problems with the orientation of the patient because the cerebellum form part of the archicerebellum, do it every day with all, and try to show what happened with the cephalorachid fluid. That is the principal things and the principal problem in Chiari malformations. When you think and you know what happened with that pressure in the head, in the brainstem, and the spinal cordon, you know what is possible to try to fix with this. And at the moment we start to that, you need to remember what is the normal or the form to do it, that type of the surgery. In open and microsurgery, that is the imaging every nose, but we try to do it, the Chiari malformation problems, and that's it. You see occipital and cranial junctions and craniectomy of the occipital and the C1 removed. And that is the scare of that surgery. You know, it's difficult surgery, it's a complex surgery, and is very, very, very difficult surgery. That types, that fellowships, that guys try to change that form. Principal Dr. Nadia Mendez try to see if you do it a tumor surgery, why do you don't go and do it a craniovertebral union surgery? What is the problem? And you see the first pictures when we try to understand what is the problem in the craniovertebral union of the Chiari, like Dr. Well say, is the C1 and the magnum foramen the principal problems. What that guys try to change this, give me ideas about what is the best form, lateral, anterior, in the forehead, and different form to approach that malformation, and return from the principles and the first step. The first step is the more easy is the best for the patient and from the surgeon. And that give the principal idea about that. The last year in May the 2025, Nadia and all the team tried to explain with this paper what is the specific steps and what is the part of you can form and fix that problem of the Chiari malformation in this paper. In the scientific neurological attack is free the case of the report at the technique. And the principle is, in 1992, we have this paper to give all the contribution about the classification of the malformation of the Chiari in 4 steps or 4 grades. And everybody know about that. But the problem is, in these four steps, in these four grades, we have a lot of lakes because not have a specific symptoms of the Chiari, and we try to summary in 7 grades, because if you know and you try to understand the malformation of the Chiari, no is only the tonsil and herniations, is all the symptoms. Maybe in the first 4 step forms, no have all the symptoms involved about that. And we try to change that and give 2 more grades of the Chiari. Is very common, and the most of the people and the patient you go with you or with me in the consult and the office come with the 0.5 or 0 grades. That is very important, because if you understand that, many patients with Chiari and the treatment like headache, like migraine, and don't help with nothing, it's possible to try for this in that form, in the form of the Chiari malformation. And the other part is necessary to go from the symptoms, and the Chicago Chiari outcome scale give the idea what is the principal symptom of the Chiari, and we try to put in 3 parts. One is for the obstruction of the cephalorachid fluid. Other one is the compression on the intracranial structures, and the other is for the dysfunction of the spinal. That last part, the spinal dysfunction, is impossible to help, because form part of the go to the years and years and years from the compression of the brainstem and the spinal cordon. But we try to help all the patients with the obstruction of cephalorachid fluid and the compression intracranial structures, with the headache, with the hydrocephalus, with the dysphagia, with the problems with the breath, autonomic symptoms. That is we can try to help. But the dysfunction spinal, the patient needs to know is impossible to fix. And is necessary in this part of the try to explain what is the dysfunction of the malformation Chiari, the myodural ligaments. We note the complex of the head and the spinal, and that union, craniocervical union, not have a flavus ligaments. We have a myodural ligaments. That is very important, because if you don't try this ligament in the surgery of the malformation of Chiari, it's like you don't do nothing. No matter if it's microsurgery or it's endoscopic surgery or it's a tubular surgery, it's necessary we understand that. And that we try to do this with the endoscopic and the open surgery. It's the same. We go from the decompression of the craniocervical union, and we know now we need 2.5 centimeters of the diameter of the decompression of the occipital, and we try to keep a posterior part of the C1. And no is necessary in more than the 85% of the patients to do the decompression of the dura madre. It's very important that, and we try to show that step by step. The first and the more principal step is go from the medial line. It's very easy when you try to do this, to lose the medial line, and for this reason, you see, we first go from the C1. At the moment we hit posterior part of the C1, we have the medial line. If you don't do it, that is very easy to lose the weight. It's very easy to lose the medial line, and in this reason, the decompression no is central. is from the one side. And no is worse that, but there's no is we don't try to do it this. And you see, it's very easy. You start to see the stem brain in the under part of the video, and it's very easy. It's very gentle. It's very candy that surgery, because we not have a loss of blood. It's very clean the view, and it's very easy when you have the tools. You can do it with no burn work. Is more with the carry some punch. But if you have a burns, it's possible to do it more faster. But is in my opinion, is little more dangerous. The next step is go from the occipital scheme. You go up. That is I touch the foramen magnum and start the drilling the occipital scheme, and start to keep. I feel more comfortable the last part of this with a scurryson punch, because it's more, I feel more safety than the burn. But that's the prefer, so you like it. Maybe you you prefer go more faster, but the principle is to help to keep and remove all the foramen magnum, and you start to see the foramen magnum ligaments and the myodurals ligaments too. And you remember the head of this drill is 3 millimeters, and you have the medial line, and you have the head of your drill for see more or less what is the distance is better for you. And you see with the 30 grades endoscope, it's possible to move and see what is the decompression you have. And the next step is cut these ligaments. This part of the ligaments is the principal part of the Chiari malformation surgery. If you don't do that, you no fix nothing, because that's complex of the neocutaneous ligaments are very, very hard to produce the more than the 80% of the compression around to the cephalorachid fluid. If you don't keep that, you don't do it really nothing. And you see is the myodural ligaments, and we start to cleaning that part for help the decompression of the cephalorachid fluid. In that part, I prefer to produce a burn around to the bad sides of the ligaments, because I prefer don't have a scarf against that. Give me to show one example on all the surgery. This is a patient to 18 years old, come with us from a very, very big headache and a little tremor, a little problems with when put the arms up, and come with us. And this guy stayed for 2 years, treatment like a migraine. And after we do it, MRI, we see the sense of the tonsils. And we try to do it and fix that with a Arnold Chiari UV decompression. And you see what is the form to cleaning the occipital scheme and go from the C1. And after we have C1, take a X-ray kit or start to kit C1. The first step is go for C1. After you kit or remove C1 arc, the posterior arc, you try to go and return from the occipital scheme. Please don't try to do it the other form, because I loosen many times in many patients. For this reason, I prefer to, and my tips, my first tip is you first go from the C1. No, not try to do it nothing more. This is C2. I do it a little bite in C2 only for show that. And the other part, the second step is go from the occipital scheme. And this is the patient before the surgery. You see, have a discoordinations, have more of the headache, but have more problems like with the problem when put up the arms. And the third step, and very important, you see in the video, is the cut of the these myocutaneous ligaments. When you start, you can see what is the result in the CAT scan. This is the result after the surgery, but the clinical presentation of the patient is this: feel better and start with out of the headache, and you see put more up the arms and don't feel like a dizziness, headache. And this is the scars in the skin. Is very thin, is very small, and you can see the moment they start to walk, don't lose the no have a lateral pulsion of the cerebellum. The cerebellum is decompression and produce very well that. My opinion is we try to change this because that is so much for one decompression in the Chiari malformation. I thinking we try to do it very the thinking more small the things, because it's necessary to change that, because the nuchal ligament in many occasions have a suffer very big damage, and that patient, because it's a young patient, need a fix in the future, maybe occipital cervical fusions, or in like Dr. Goel, C1 C2 fusions. But with this type of the surgery, in endoscopic surgery, that is not is necessary. Let me to do it one information more. When you punch the first hit in one fight, whatever fight to do, and you help to get a lot of people, the people come around, try to do it part of this. That is the one option you have, to try to don't, you can only you can do it. Don't try it, because if you try it, maybe you lose in some cases, but in many other cases, one of these you have success. Remember, when you have this type of patients, if you keep the compression of the occipital as C1, you fix more than 85% or 90% of the symptoms. Only when you decompress, the foramen magnum and the C1 cranial union. Okay? Remember, no matter if you do it a very big decompression of the occipital and you keep C1, if you don't keep the neodural ligaments, you don't do it nothing for this patient. It's necessary you keep that ligaments. It's necessary you understand that part, because it's the more important part of that type of the surgery. It's necessary to do it very gently, you take your time. No is a competition, no is a NASCAR competition. It's necessary to understand that part. You feel the ligaments. It's very easy when you know how is the form to do it. Thank you very much. Welcome, Mexico, wherever you like. This is your country. This is your house, Assam. Thank you very much for the kind invitation. And it's my pleasure to stay with us. And everybody have a question, please tell me. It's my pleasure to stay with all of you.
Thank you, dear Dr. Rodolfo, for your excellent presentation and for sharing your valuable experience with us today. On behalf of all participants, I would like to express our sincere appreciation for your time. Thank you. And before going to questions, I want to ask one question. How do you manage patients with associated syringomyelia, and does the presence of the syringes influence your surgical strategy?
With syringomyelia, I have right now 51 patients with the yesterday patient, and with syringomyelia we have 8 patients. And after the surgery, in 6 of these patients, 2 months after the surgery, reduce a little the syringomyelia. But the principal is the symptoms of the syringomyelia. The central canal produce the patient feel better around to the feelings in the numbs and recover the force in the arms. That is right now the experience with the syringomyelia. But the patient more time to go on the follow after the syringomyelia is 2 years. It's only 2 years. We need more time from have more evidence and more information about that. No.
Okay. And one more question. What are the radiological criteria you use post-operatively to define a successful decompression?
Okay. The decompression is I see the head of my drill.
Mhm.
From the subsection decompression, I need 5 heads from the linea media from the both sides and 5 heads from the magnum foramen up. That is my success and my I thinking that is a success. I have in all of the diameters of this compression. We have one patient to do it 5 centimeters of the diameter and not change nothing with a 4, 3, or 2.5 centimeters. And for this reason, but also has is 2.5 centimeters because it's more easy, and it's more fast, and the clinical result is the same.
Thank you. And Dr. Edgardo Montalogno, excellent conference. Congratulations, Dr. Guerrero, he says.
Thank you.
And from Turkey, Professor Mehmet Seçer asked about, do you have any visual complication after endoscopic surgery, example, Thurston syndrome?
No, thanks God, no, right now, no have the more complication we have is ecchymosis in the posterior part of the neck. And in one, I thinking have because in 4 of these cases, we do the durotomia and produce a decompression and duroplastic with a duragen. And I thinking we have a cephalorachid leak, but that leak resolved in 1 week. It's a no, it's an open leak. It's a compression leak, containing, and 1 week after the furosemida and rest the patient, resolve it with that. No, was necessary to do it resolve with a surgery too.
Okay. Dr. Yaksh Sompura says how to manage syringomyelia.
What again, please?
How to manage syringomyelia.
How many? 8 patients with syringomyelia.
Yeah, how to
How to
manage? How to
manage.
manage? If
Okay. The manage is a conservative form. Only with observation, the patients have that syringomyelia. That right now, the patients with syringomyelia and Chiari, we don't need a drainage or a collocation of the drain from the lumbar body on the mielo syringo pleural or something like this. Only see it, and right now from the 8 that patients no need other type of the manage.
Yes, thank you. We see the person in dark here, Dr. Yuri Lonkowski. And he says, thank you, my brother. It was excellent as usual. What about blood pressure? Maybe
The
we
blood
can hear from you the question from him.
maybe
the blood
we want to ask by himself.
the blood pressure of the patient or my blood pressure?
Do you mean do you asking the blood pressure of the patient during the?
Yes.
Oh,
Hello, my brother. Uh,
Hello.
hi brother. That
uh,
is Yuri.
your presentation. Hello from Ukraine, from Kam'янsk-Подільський. Thank you so much for visiting our country, for everybody. Thank you so much, my brother. And I saw your presentation third times, but every time I know something new about your excellent technique. But I every time forget to ask you a question about blood pressure. Is it possible to hold blood pressure under very low or not? Or it's not mandatory?
No, no, it's mandatory, but the blood pressure maintained in blood medial blood pressure between 85 to 75 blood medial blood pressure, more or less than that. And at the moment when you open the myodural ligaments, the blood pressure of the patient every time goes down a little. And that is necessary. The anesthesia stay with aminas and see the blood pressure of the patient, because it's very, very common, that part.
And last question: what about the hike of the water for I mean for water floor? What a
No
hike?
more than 1.5 meters.
No more than 1 meter, yeah.
No more than 1.5 meters. The 1.5 meters, and the other, you every time see the beat of the dura madre. Is more important than the pressure of the water, because the water bump gives you 20 millimeters of the mercurio or something like this, but it's in a specific pressure to help in the site of the surgery. Is more important for me. See the beat of the dura madre.
And the last question: what about? I saw that you use just the usual, just casual drill, not with diamond bore. What do you think about using the diamond bore in this case? I think that it was
is very good. I think it is better, but in my cases, I try to go more faster, and I have a little of more confidence with a no diamanter burn. But is great, and depends on you feel comfortable, brother.
Thank you, my brother. Thank you so much. Excellent presentation. Thank you.
Thank you very much. Glad to see you, brother.
I'm too.
Okay. Thank you, Yuri, Dr. Yuri. Efecan, there are many distinguished participants today.
Yes.
Here. Brenda Bueno from Mexico also asked 2 questions. Maybe she wants to ask by herself. And also there is Göksal Günerhan, Dr. Göksal Günerhan. Dr. Günerhan gave a lecture actually 1 year ago, and about endoscopic treatment of Chiari malformation. But I think his technique is a little bit different, and maybe he wants to talk about it. Also, there is Musa Ibrahim here. Yeah, I met Musa Ibrahim in Mexico. Also, he is from Nigeria. Maybe he wants to talk and he wants to say something. Also, Professor Suat Çelik from Okan University is here. Mehmet Seçer from Alanya University, professor, is here.
Yeah.
If someone wants to speak, Dr. Günerhan, would you like to say something? You gave a lecture last year about endoscopic treatment of Chiari malformation. Dr. Günerhan? Okay, maybe. Dr. Ibrahim, Dr. Musa Ibrahim, would you like to say something?
Hello, thank you. This is a greeting from Nigeria.
Yeah,
hello. Very nice presentation. Hello, Dr. Rodolfo.
Hi, Musa.
How are you? How's Mexico?
Great. The weather is great, and right now is a good time for stay here. Welcome.
Wow. Yeah, it's a very great presentation, actually. And that's why I always say endoscopic spine surgery, you have to learn, you have to be vast. You have to learn UBE, you have to learn monoportal also. This is the power of biportal. Thank you.
Thank you.
Thank you very much for
Thank
your
you.
work,
Thank you.
man.
Yeah, thank you.
Okay. Is Brenda? Okay. It's better to you read the questions, Efecan.
Yeah, Dr. Brenda Bueno says, congratulations, Dr. Guerrero. Excellent talk. And she asked about is the irrigation system you use gravity fed?
Yeah, I think
Yeah,
Yes.
gravity fed.
is gravity in
Yeah,
my irrigation is
150
gravity.
centimeters.
Yeah,
You said.
I don't use a bomb. I don't feel comfortable. I have two or three patients in the cervical surgery with bomb. We have hydrotrauma after the surgery, and after that patients, I never use a bomb again. I only use a gravity.
Yeah.
Okay.
And
And
Dr. Azmi Menshav, thank you, Dr. Rodolfo, for this great presentation, says.
Thank you.
Professor Suat Çelik wants to talk, but before I want from Dr. Göksal Günerhan, because he gave a speech 1 year ago about on the same topic, actually. Okay. Dr. Günerhan?
Yes. I want to speak my wife translate.
Okay. So
Hi, everybody. I'm as a translator here.
okay.
Okay, yes, he can
Okay.
speak and I can translate to you.
Okay.
Başarılı bir cerrahi
It's
sunmuş
a-
kendisi. Tebrik ederim.
Yeah, he wants to congratulate the doctor who did the presentation because of his success in his operations.
Ben de yaklaşık 6 yıldır endoskopik assistant, endoskop yardımlı cerrahi yapıyorum.
I've been doing nearly for 6 years this kind of operations with endoscopic assessment.
Assistant.
And
Endoscopic
yes, sorry.
assistant.
100'ün üzerinde vaka serimiz oldu.
I completed nearly more than 100 patients with these operations.
Gerçekten minimal invazif yaklaşım bu ağır cerrahide önemli sonuçlar veriyor.
I can truly admit that this kind of minimal invasive surgery has great and important effect on these kind of operations, these kind of patients.
Fakat daha ilerlemeye açık bir teknik.
But of course, there are more further operations to improve this kind of techniques.
Teşekkür ederim.
And I want to kindly thank you to all of you and good evening for all.
Thank you so
Thank you.
much.
Thank you so much.
Okay. Professor Suat Çelik.
Yes, it was a very brilliant. Can you hear me?
Yes.
Yeah.
Yes, it was a very brilliant conference. Thank you to Dr. Rodolfo. But in several cases of Arnold Chiari, there is a hydrocephalus and syringomyelia is complicating to all cases. In several conditions, only bone removal is not effective for my experience, and we need duroplasty sometimes, and we need reoperations. I want to ask to presenter, do you reoperation some patients, some several patients, and can you turn to open surgery? What about your experience? If first surgery, first endoscopic surgery is not enough, did you turn to second operation, open surgery or duroplasty?
Okay. In my cases, thanks God, never have a reoperation after that surgery. Remember that patient is the younger patient, is a baby, because when you have hydrocephalus and problems with the syringomyelia in that type of the patients, is a very young people, very young patients. That patient need derivations, abdominal derivation of the cephalorachid fluid, and after that try to fix the cranial union problem. And never try to help or fix all only with the decompression and duroplastic. And that is different patient, because that patient is the patient younger teen, like the 15, 40 years to the 30 years. That is the most of the people that type of the patients to come with us. The baby patients or the born, the babies is different. The hydrocephal is mandatory to fix first, and after try to fix the cranial union problem. And right now we don't have a intervention with a patient. Obviously, that is a very young approach, because only have a couple of years. We need to see more the patients and have more information, but it's a one approach to be maybe a good future, and maybe that is a gold standard in a couple of years now.
Thank you.
Thank you.
And Professor Mehmet Seçer reminded his question, but I think you already replied it. Thank you. I asked my question about Terson syndrome, and you replied you never met such a complication, right? In these kind of operations. Okay, and there is a question from Germany. Okay.
Yes, Jan Tahran. Greetings from Cologne, Germany. Have you experienced with biportal C1, C2 fusion? Thank you all for your efforts.
Experiencing what? I'm sorry, Afak?
C1, C2,
C1,
atlantoaxial stabilization.
C2, C1?
Yeah.
Yeah.
Yes, I have more traumatic with UV. Traumatic people, I do it decompression from C1, C2, C3 in occasions, and it's a good form to do it, because less blood is more safety and is very quickly the recovering. But it's only for the decompression, because in many of these patients we need a fix after that. It's only for resolve the emergency, but in many cases we don't have a craniocervical fix tools, and in these cases we do it the decompression, and in the second time we do the fixation of the craniocervical union, but it's only in trauma. I don't have another one, and I do it a tumor of the C2 in one occasion in Madrid with Doctora Elsa and Ariel and Raúl Echeverry, but that is my only experience in UV, in the C1, C2.
Yes.
Just to be clear, Dr. Rodolfo,
Yes.
I didn't get it. Did you perform any endoscopic fixation? Endoscopic?
Only in lumbar, in
No.
cervical.
The question is about the C1, C2, atlantoaxial.
No, I don't have a case.
Do you know, is there anyone who performed this kind of surgery in the world?
Yes, I know the Dr. Samway right now start to do it cervical fixation with endoscopic help.
In Mexico, or I don't know.
No, in Mexico, no.
Okay.
It's in China.
Atul Goel don't do endoscopic surgery, Professor Mehmet Seçer. Atul Goel don't do any endoscopic surgery. He always
No, Professor Artur Goel did open surgery,
yeah.
and from the result, they are not carried with a fixed C1, C2.
Yeah. Okay, Efecan.
As far as I see, there's no comments and questions. I want to give the floor Dr. Hasan Kamil Sucu.
I want to thank again Rodolfo. It's a great pleasure to see you again, even in a online platform. Yeah, I am very happy to know you, to meet you in Mexico. It's a great pleasure. It was great pleasure for me, and I want to congratulate you one more time for the Congress. It was a huge success, I think. Thank you.
Thank you very much. Really, it's my honor, and glad to see you, brothers. And that's you receive a one big thumbs for everybody, and thank you very much. See you next time.
Yuri, how can
Yeah.
you do that? Okay.
Bye bye.
See you. Bye bye.